And so we are now going to go to what was going to be item 4 as moving up. So we're going to start with the South West London Health and Care Partnership. So if I can ask Sarah Blow.
Yes, I'm going to. So a bit of background to this talk. I think we were going to have a bit of an informal discussion about South West London, what we do, and where we are currently. And obviously my colleagues are here to talk to you about some specific pieces of work that we've been doing at borough level, but also across South West London as a whole. So I was hoping that was going to work. Yeah, it does. So what we were going to do today was talk to you about what an STP is, share the work that we've done about refreshing the STP in South West London, and also looking at some of our emerging priorities, particularly where we've got our clinicians involved, but also the borough level work, as I said, the long-term plan which was recently released, and a bit of an update on some of the achievements that we've had, and then there's some time at the end for some questions if anyone has any questions. So what is an STP? Well, it started off as a plan, so when it was initially thought of, we got the guidance nationally, it was a plan, but it has turned into a partnership over a period. And what we do in South West London is we bring all the organisations together, the NHS organisations, but also our partners in local authorities and also local people. There are 44 STPs nationally, and there are 5 STPs in London, which you have a list of here. We're actually the smallest STP in London. I think we're about 1.4 million, and I think if you go up to North West London, I think they're around about 2.2, 2.3 million, so we are the smallest overall. So who's in our health and care partnership? Well, all of the 6 CCGs are in our partnership. We also have the 6 local authorities within the partnership, and representing you in that partnership, we have the actual programme board and the chief executives, often more directors of public health, directors of social care involved in that. But we also have a regular meeting, we call it the leadership group, where the 6 CCG chairs come together with the health and wellbeing board chairs across South West London and myself, and we talk about strategically where we're going and how we work together. We have all of our NHS providers within that programme. So we have, and you've got them listed there, we have community providers, mental health, we've got 2 mental health providers and all our hospital providers. We have our GP federations who work with our general practices locally, and we have 1 per borough, so we have all 6 of those represented on our programme board. The London Ambulance Service, and we also have Health Watch and voluntary sector representation on our programme board. So it's quite a large group, to say the least. And we have an independent chair. I don't know, you may know her, but Cheryl Cockle is our independent chair. She was previously a local authority chief executive in East London, and also has been a non-executive director on a hospital trust in North London. So we refreshed our STP plan, and there were good reasons for us looking at refreshing it, because when it was originally put in place, it was quite a top-down process. A lot of numbers thrown around millions of pounds to save, and there was a lot of discussion about South West London having all of its hospitals at risk. Generally, people felt that they didn't buy into some of the numbers in the plan, and stakeholders were not necessarily signed up to the priorities. So we said, let's try and get everyone together and actually develop a plan that is locally owned and locally builds our plan for the future. So we refreshed the approach, and we've emphasised, and I think it's really important, prevention and early intervention, and tackling some of the inequalities that we have across South West London, about the local partnerships, locality teams. We talk about populations of 30 to 50,000 population, which is where you get real communities working together and trying to wrap our care and health services around them, working with the voluntary sector. We're also looking at actions to deliver improvements for local people and looking at the wider determinants of health. And we want to make some real progress around with our local populations over the next few years. So we engaged with a number of people around the refresh, and we listened to a lot of the feedback. And with our stakeholders, we decided that we would have local health and care plans at a borough level that would feed into our overarching plan for South West London. So we developed a document that took into consideration all of the feedback that we had, and that was our stage 1, and we published that in November 2017, and that's on our website. It's actually on all of our CCG websites, there's a link to it, so you can go and have a look at that. And now we're in the process of developing our local health and care plans at borough level in order that we can publish those later on this year. And I'll talk a bit later about it, but this is how we've managed to get feedback from our local communities for the refresh. So last year, we did a lot of work with local communities. We've actually got some information that we can send to you about some of the output of that, and we did grassroots engagement, we did public and patient groups, and we actually did a lot of going out to communities in the groups that they already had going. So what we didn't do is set up NHS groups. We went to mums and babies groups, and we went to, I think somebody went roller skating. We went and did some quite interesting things with the local community to try and get their feedback about what they want from health services and what's important to them. And so we did this direct involvement. We did wider participation, we did some targeted engagement because, and this Andrew will talk about, that the I Don't Feel is from our Children, Young People Mental Health piece of work. And then we produced a document that took all of the engagement that we had done across South West London and we put it into a report. And we split the report into areas of interest, so such as children, young people, mental health, or older people, but we also then split it down by borough level, so each borough has a report that says this is what your local people think about the NHS, and these are the things that are important to them, and you can access that online. Okay, so what we then did, from all the information that we had gathered from working with our partners and also with our patients, is we then looked at, so what is it we're really trying to do through this refresh of our plan, and we've got some key messages that we think and were put into our refresh plan for everyone. One is about local approach works best, which is why we're doing our local health and care plans. So we really want to strengthen the focus on prevention and keeping people well, because we don't want to be the NHS is the treatment centre. We want to be a service that is supporting to people to be healthy as well. The best bed is your own bed. Actually, we want people to be independent. We want them to be supported in the community. We only want them to have to go to hospital if they really have to go to hospital, because that's the right thing for them. And care is better when it's centred around a person and not an organisation. One of the things that we want to do by working in partnership, both at a local level and across South West London, is sometimes our organisational structures and our and the way in which we are set up gets in the way of care for individuals, and actually what we should be doing is making that invisible to the individual and giving them the care they need. And South West London Health and Care Partnership is coming together to talk about children, young people, mental health. That was the priority that we identified when we did our refresh some time ago. And we want to make sure that we keep involving people at a local level. So those were some of our commitments. Which leads on nicely.
Thank you, Sarah. So I'm the GP Chair of Merton.TV. I'm also the co-chair of the South West London Clinical Senate, and I co-chair it with Jane Wilson, who's the Medical Director of Kingston Hospital. And the Clinical Senate is our senior clinical leadership forum in South West London, so we've got all the different GP chairs of the CCGs, we've got the medical directors from the hospital trusts, from the mental health trust, from the community service providers, we've got GP representation, we've got public health, we've got some patient and public engagement representation. And we've been encouraged, as part of the refresh, to really engage with it. I think we feel like we own the refreshed SDP plan. It feels much better than the previous version. It actually feels now it's about trying to do the right thing for patients, which is something that as senior clinicians we are very much behind. I think Sarah's really encouraged us as well to start to shape the vision for South West London, so that's a key piece of work that we've been doing. So we came together to say, what is our clinical vision for what we want to achieve in South West London? And this slide summarises it, so the 3 bullet points. We're going to join up and continuously improve health and care so that people experience seamless, high-quality services when they need it. And a key part of this is about getting rid of some of the handoffs between different organisations where people get passed around and someone says, sorry, I'm going to have to refer you to someone else to do that for you. We don't want health and care to feel like that to people. The second thing is we're committed to improving the health and well-being of our population and our workforce, and we want to champion healthy lifestyle choices. So that's not traditionally something we've focused on in healthcare delivery. It's often been about treating people when they get ill. We feel our responsibility as senior leaders of the South West London system is to try and...
Sorry, I seem to be lost in the slide.
Yeah.
You've not got these? Do you want to just follow the slides on the screen?
I don't know why you haven't got the reason.
That's the report you've got there, but you did say these report.
Joe, can we just run some off and just use them around? Well, people might actually be very helpful.
Yeah, it's just hang on, sorry.
We'll carry on and we'll get you some hard copies. We can send it over as soon as we can.
So the other key thing we wanted to pull out was that we want to encourage innovation, we want to embrace technology, and we want to use data to help us make the right decisions so we can really invest in the stuff that's going to add the most value to people in South West London. We also want to make sure that we're listening to what both our residents and our frontline staff tell us. So we've decided that we're going to, as a South West London senior clinical leadership, focus on 3 overarching system priorities for South West London. And this is about what we think we can deliver better at the South West London level, because there's loads of great stuff going on at local level, be that our partnerships of local boroughs or our individual boroughs, or even down in individual localities within our boroughs. But this is about what we think we can do better working together across South West London. The first thing is enhancing clinical care and standards. We do have variation in the quality of care across South West London. We do sometimes work to different standards. We think it's really important we set the same standards for some key areas across South West London. We think we can do better, and we can learn from where it's happening to the best standard and copy that across South West London. We're going to do that on the basis of looking at good data, and we're going to use digital care to support that. The second thing is taking responsibility for making South West London a healthy place to live and work. That's really critical because I think in the past the STP felt very health-driven. We really do want to make this about involving local authorities. We've had some really good engagement in the Senate with this, and that's what prompted us to say it's not just about healthcare services, it's about us collectively taking responsibility for South West London. The third thing is workforce. So in every public sector organisation, I think our workforce feels tremendously pressurised and morale is an issue, and I think it's our responsibility to do something about that. And also to think about how we use our workforce most effectively and start to think flexibly about the workforce and allow them to work across organisational boundaries, not to get stuck in some of the red tape that we wrap things up in. So they're the 3 system priorities. And what we're going to do, we want to make sure that they're owned by every organisation in South West London. So we have a senior clinical leadership team in the Senate, but in every organisation there are different layers of clinical leadership. We want to engage with those clinical leaders and make sure that we use their knowledge to shape our priorities and that they own them. More than that, we had some challenge. We were going to have a clinical conference. We were challenged to say this needs to be a clinically led conference, but it needs to include your directors of social care, your directors of public health, your directors of children's services. And we also need to bring the exec from these organisations, from our healthcare providers, into the room so that we own it together. Because sometimes what I've seen is clinicians in organisations wanting to make change happen, and unless they have the support of their exec, and unless the exec are bought in, sometimes it doesn't happen. So that's what we're going to do. In April we're holding a conference, and it's going to be about us looking at those system priorities, but also starting to think through what are some of our more focused clinical priorities that we're going to deliver at South West London level. So we've already committed to doing children and young people's mental health and emotional well-being. We think we can add value by looking at respiratory care, diabetes, cardiovascular disease across South West London, and we know that there are improvements we can make looking at our existing data. The final thing is outpatients. So there are great pieces of work going on with some of the acute trusts. I lead a programme of work at St George's looking at outpatient transformation, and there's some really exciting things we're doing. But actually, by working at scale, we can deliver much greater levels of change. What we want to move away from is where patients wait 2 or 3 months to go and see a specialist to get either a diagnosis or advice on managing their condition. And we're already starting to work digitally where a GP can get advice the same day or the next day from a consultant about how to manage a patient better. And that's really the way we want to shift access to specialist care in South West London, to make it much more flexible, to meet the needs of patients and to be much more responsive. And not only do we think that will give much better care for patients, but it will save money as well, which will allow us to invest that money in areas that we determine to be of greatest value for patients. So, one area that we've mentioned a number of times is children and young people's mental health. So we set it as a system priority. I've been involved in leading this programme of work, initially with Jed Curran, the Chief Exec of Merton Council, and John Goulston, who is Chief Exec of Croydon. And we started with the problem of self-harm, because in South West London we have high levels of self-harm in our children and young people. And what was quite staggering was looking at the number of teenage girls who were self-harming. And when you look at the graph, it's just shot up. And that's just, it's a sign that something is not going right. So we did a piece of work where we got together a huge steering group which involved people from different healthcare organisations, people from local authorities, from the voluntary sector, we had some teachers, and we had some representatives of children and young people. We looked at the problem of self-harm, and what we agreed was that if we really wanted to make a difference, we had to start intervening much earlier. So we developed a programme of work focused on improving emotional well-being and resilience among children and young people, and that is focused around schools. So in every borough in South West London, in all 6 boroughs, we have created a cluster of schools. So we've got a head teacher who's taking responsibility for leading that cluster of schools. They cover about 5,000 pupils in each cluster, and we're delivering a whole school approach in all those schools. It's a mixture of primary and secondary schools. And sorry, no, I've gone too far. I can't go back. Never mind. I'll talk to you about it. So, basically, you've got to have it again. So go back one. So I'll talk to you about the whole school approach. As part of developing this strategy, we did engagement with groups of children and young people, and actually some of the stories that they told us about how existing services were not working for them were pretty tragic, and that acted as a real motivator for us to do something about it. We've got a video of one of our young people who's now set up a peer support charity, but she self-harmed throughout her adolescent years, and she tells a story about how when she accessed healthcare services, basically people said to her, "You're not ill enough to get support." So she cut herself deeper and deeper and more times until finally someone took her seriously. So we did engagement with children and young people, with groups of people who've been through services. We did an online survey. In a week we got over 1,200 responses from children, young people, parents and carers to help inform the strategy. So that's how we came up with the whole school approach. The whole school approach is about setting the right ethos in the school. We have recruited a mental health support worker for each cluster of schools, so they're a senior psychologist. They're going to support the schools in delivering the whole school approach, and they will do work with teachers in training teachers how to deal with mental health better. They'll support delivery of content to help our children and young people with emotional resilience in PHSE lessons. We've commissioned online support and online resources for our children and young people. We're creating a directory of wellbeing services for children and young people in each borough that they'll be able to access. We're commissioning online counselling for children and young people. The mental health support worker in each school will be delivering targeted interventions, so one-to-one support for more vulnerable children and group interventions. We've commissioned a programme of work for parents, so it's called EPEC. It was piloted, it's been delivered by South London and Maudsley Mental Health Trust. Basically, it's a train-the-trainer model for parents. So they go into schools, they train the parents how to train each other, and they start to set up parent support groups for parents who've got children who have mental health problems, but also to help parents recognise those children and support them better. We are going to be evaluating the programme, so we've already started the process of commissioning a research partner. We will be surveying all the children in these pilot schools in years 5 to 8, so to do a baseline survey of their mental well-being, and we'll be repeating it in a year's time to show that it's effective. And the purpose of this is we're not working with every school, we're working in pilot clusters, but the plan is to show that it works, and if we can get the right data that shows it works, we can create a business case to roll this out to every school in South West London, and that is the scale of our ambition. So, going on to the next slide, on the back of that work, we then applied to be national trailblazers for children and young people's mental health. So 3 of our boroughs qualified for that. There were certain entry criteria. Incredibly, we were successful for all 3 boroughs of Merton, Sutton and Wandsworth as in our application to the National Trailblazer Programme. So we are the only area in the country that has a cross-borough trailblazer. So what that meant was we've got 1.85 million extra investment into children and young people's mental health. So what we are doing with that is the initial cluster of schools that we have to expand that in those 3 boroughs to cover 8,000 pupils. And rather than having 1 mental health support worker, the funding delivers 2 senior psychologists to work with the cluster of schools and 4 mental health support workers. And they're being supplied through a Health Education England pipeline. One of the key issues in children and young people's mental health is the workforce. It's not just the money, it's about having the people to actually work with children. So this is a programme where they're graduate entrants, they get trained on the job, they're basically doing 3 days a week in university being trained and 2 days a week in the schools starting to learn about the local system. They're supported by the senior psychologist, and in the spring term they'll start to deliver some interventions with the children. So that's where we've got to. We really hope that, again, showing that the mental health support team approach as part of the Trailblazers is successful, we're hoping that we'll be able to bring the other 3 boroughs along into the second wave of Trailblazer to be able to roll that out more widely as well. So that's where we're at with that project, which is very exciting. So that's the South West London work. What we're just going to talk to you a little bit about now is the local health and care plans. So we have a South West London strategy that is very much made up of our local health and care plans, plus the stuff we think we can do better across the top. And that was very deliberate. It's very much a bottom-up approach. What we're doing at South West London is stuff that can be done better at local level. We want it to be done at local level. We will only do stuff at South West London level if we're going to add value and if we can do it better once. We agreed this approach in 2017. The local systems have since then been working on their local plans. In November last year, we held the health and care plan events in every borough. Now, you might well have encountered those or been involved in some way. There were design groups shaping them, and that was very much a partnership between health, social care and the voluntary sector in each borough. And the aim was to define what were the key things that we were going to do over the next 2 years in each borough that would have the most impact on our population. We held those 6 events. On average, we had 150 people at each event. And really what was looked at those events and what each local health and care plan involves is looking at 3 areas of the life course. So start well, live well and age well. And it's really key that they're co-designed by health and local authority. They need to address the needs of the population. We aim to outline the local vision. Part of this and the ongoing work will be looking at financial challenges on actually delivering proper support for people in the boroughs, and that will be thinking creatively about how we start to work as a local system to address some of those financial challenges, and also looking at the workforce issues and how we start to create a sustainable local system in our areas. Part of it as well is having local delivery of some of our South West London priorities. So each area is being asked to describe how they'll help us deliver on children and young people's mental health, and also they will be asked to help us in delivering some of the national performance targets. So we had an event in Merton. It was brilliant. We had it at Track 89. We had loads of people from different health organisations, really good representation from the local authority, from the voluntary sector. We had 60 people from the population who don't normally come to these sort of events. We had a beautiful infographic drawn afterwards, and we've had videos made of all these events. It was really great, and we showed us at the Merton Health and Wellbeing Board last night. It's really inspiring. Just to give you an example, in Merton, what we're doing on the 3 areas, so we're focusing on start well. Obviously we're doing children and young people's mental health. We're also looking at children and young people's community services, particularly pathways into adulthood. In the Live Well area, we're doing primary care development, so trying to get our practices working better together at scale. We're focusing on East Merton and what we're doing around the Wilson Hospital. We're focusing on primary mental health care and improving our IAP service so that it doesn't just deal with mental ill health, but it deals with people with long-term conditions and their associated mental ill health. And the other Live Well priority for us is diabetes. Finally, our Age Well priorities in Merton are creating a dementia-friendly Merton and health and social care integration. And I just wanted to say a little bit about health and social care integration because we've got a lot of work to do, but in Merton, we were, 18 months ago, our delayed transfers of care from St George's were one of the worst in London in getting people out of hospital. So the Director of Social Care in Merton and the Managing Director of Merton and Wandsworth CCGs got together to try and address the problem. So they went into St George's and they found that the St George's clinical team, Community Services in Merton, CLCH, and the council had different teams trying to deal with these patients, but they weren't talking to each other. So all they did was they got the teams talking together. They created a meeting every day where they sit together and they talk about the patients. And in the space of 3 or 4 months, we went from being one of the worst performing in London to one of the best areas in London for transfers of care. And that's just an example how some of this is not difficult, it's just actually about starting to work better together. So that's Merton. I'll hand over to Jeff to talk about supplement.
Thank you very much. I'm just going to go quickly through something, equivalent health and care plan. We want to show you a video because we're really excited about seeing the video that's already been mentioned, and a little bit about the feedback that we've had from these events and where that's going to take us. So what you can see on the infographic is the Sutton Health and Care model. If you look carefully at these infographics, there is one for each borough, and they're all very different, and they're informed by local voices and local plans. A health and care plan for Sutton will set out how we are currently working with our local borough, making sure that what we are doing is incorporated into the Sutton plan, and then the Sutton Health and Care plan will be part of that. It also will help to, we will be aiming to show you what our aspirations are for the future, and in the same way using the Start Well, Live Well, and Age Well priorities and Sutton that we're going to follow with Merton and the other boroughs and using the children's young person mental health work. We're also going to be doing work with children and learning disabilities, with physical disabilities, and also work with children with special educational needs. And in the Live Well category, we want to support adults with learning disabilities in the same way and prioritise that work stream, but also creating local networks for patients and residents to create a healthy lifestyle. And in the Age Well category, making sure that we combat loneliness and social isolation and improve supported discharge from our local hospitals. We've already seen that there are results in some of these areas where health and care are integrating effectively together. So Sutton had a vanguard, a national vanguard attached to some of its work, and it produced significant and important results. And one of the things that have come from that is the Red Bag scheme. The Red Bag scheme helps to support patients when they were going in and out of hospitals. It would seem to be a nationally important way forward to support our patients using hospital services, and we've shared it across the other boroughs in South West London. And those in other areas nationally have had a look at that scheme and have adopted it as well. We want to make sure that development and working with our local partners is enhanced and retained with our local work with St Paul Hospital, with our Mental Health Trust, our community services and also GPs. It's really important that what we are doing...
Look at people starting well, living
well.
well.
Move on to the video. So I've introduced the way of doing it. So each of the local health and care events for our boroughs in South West London were recorded. There was one for each borough, but we also produced a film that supported a South West London overarching view of what we did. And we have shared each of those videos and they're available online. What we would like to show you is the South West London film that summarises what we have done.
We want to look at people starting well, living well, and ageing well. And I think that's really important because we're looking at the whole life cycle of an individual who lives in Merton and making sure we do absolutely the best for them.
Today I've mainly focused on conversations about mental health, because personally that's something that I suffered with this last year. I'm hoping that I'm going to be able to influence plans, and that feels amazing because it needs to come from the people themselves that are suffering with these things.
Actually, it's been very lively, very engaged people, and great to get so many people together to talk about these kind of issues.
The energy in the room is just incredible. There's more than 100 people here, people from all different walks of life. We've got people from the council, obviously, from the NHS, from different voluntary and community groups. But we've got an awful lot of people here who are talking about their lived experience, and I think that's just so powerful.
I'm here because I want to get my view as a young person living in the borough of Sutton across to the people who are at the top. And I feel like it's very important because we're the next generation, so the changes that are happening now are going to affect us, and we should have the say in how our future shapes.
Thank you for actually giving me the opportunity to actually stand here, give my voice across as a young person in Sutton. So thank you for that, and for actually accepting what was being said by us as the young people and sort of taking it in and trying, I guess, change the future for everyone as well. So yeah, thank you for that.
I think we need to work as a system, we need to work on integration and how we can work together to make healthcare and social care enrichment even better than it is.
How do we make prevention everybody's business? How do we create healthy communities? How do we reshape healthy lifestyles and services to enable people to think about how they can look after themselves better? And then, how can we prevent, reduce and delay demand for health and care?
So I've come to this event today to listen to members of the public and hear some of their ideas about what can make Richmond a more healthier borough, what can we do to improve some of the services that we already have.
What I really want to get out of today is to be able to hear firsthand what carers and patients in the public feel about services within the borough and how we can create a better system for the patients to be able to navigate.
We have to do things differently. I sense there's a real commitment to trying to do those things differently.
What's important is to have people from lots of different backgrounds, with lots of different health conditions and situations to really feed in a variety of views.
My particular great concern is the rise of mental health for young people at school. We've got a lot of young people that are being excluded because their bad behaviour is just escalated, and we're struggling to know what to do, really.
Everybody who lives in the borough knows that if we're going to have great healthcare and services, then we need to get things more joined up. So today is about not only asking ourselves what are our main priorities, but then also the different people here, it's how can they then work together in a more partnership fashion to actually do a better job of delivering on the ground for local residents.
This health and care event has been really great. We need to improve or increase our collective work across health and care at all levels, and it not just be something we say, but that we actually implement it.
Making sure that our Croydon residents and people who use health and social care services can access the care that they need when they need it, and that their experience is as good and as seamless as it can be, is all of our responsibilities.
What's really good about today is we've got the local authorities and we've got all of the health system as well as local people and practitioners coming together, because we're not going to make a system that really joins up unless we all come together.
This is about shaping our future and doing it together, and that is from every single discipline. People of Croydon, specialists in Croydon, health, social care, local, everyone together, forming a vision for where we can move forward as Croydon.
I'm a care assistant for people with Alzheimer's and dementia. I just kind of want to thank everyone actually, because I didn't think that I would actually learn so much just from coming. I think it's actually going to help me change the way I work and the way I do things at work and the way how I handle different situations. So thank you.
So there's a longer film for every borough. If you wanted to get access to that, you can do so. They were really inspiring meetings. Humbling as well for those that were there, because actually the real stars were the residents, the patients, those young people that presented today. had really good views, and actually incorporating those views into what we were doing going forward was a really valuable thing that came out of that. So there was some feedback for us from all of this, and that was feedback was captured purposefully so that we can form the process going forward. People felt the events were really valuable. The individuals from your communities felt their contributions were listened to. I think that is vital and really important in what we were doing. There was an increased knowledge about what we were doing that spanned the health and care partnership. And a recognition that we actually were getting close to the right priorities, and also a theme that we were going to make a real difference if we followed this through. Thank you.
So we were going to talk about the long-term plan, but I wondered if you wanted to pause and do some questions.
I think it's run over a little bit.
Because we thought this would be most of the discussion today, because that's what we intend to do.
I'm wondering if, I think what would be good at this stage probably is if you wanted just to look at the questions would be good. But I also think, obviously, I'm looking at time as well, but also I think looking at your programme update as well would be, I'm just seeing that's the other item. But I think in terms of the questions, I think it would be very useful to see if anybody on this particular part.
So that's the STP programme.
That's right.
Yeah.
So I think it's good to have the questions now. I think would be.
Do you want me to just very briefly, I won't even talk to them, they've got the next 3 or 4 slides is about the long-term plan. It was obviously published. If I just say a couple of words on that, then I'll finish that section. And then you can do these lists.
Yes.
Okay, so just so it was published, actually probably a few weeks ago. The new long-term plan is over 300 pages. We are working on it locally. It puts in place for us a number of priorities for the NHS as a whole. It does actually follow the Start Well, Live Well, Age Well. We got there first, guys, but the national team have copied that. That's my story, and I'm sticking with it. But what we're doing in South West London is we're now looking at that, and we're trying to feed that into all of the plans that we're developing. We will have to produce a new South West London plan, but actually, luckily, because of the work we're doing on the local health and care plans, that will feed into the timeline, and we don't have to produce that until the autumn. So what we will do now is we will be working with the local health and care plans, reviewing the long-term plan and how that feeds into our plans, in order that we can publish a new plan for South West London in the autumn. But when I say a new plan, it will be the work we are doing now. I do not expect it to be something different to what we are already doing. So there's a little bit of information in here about some of the work streams we've already got going on. And I do want to just, at the very last slide, I think just really important, is that we talked about it, but we've achieved a huge amount in getting additional funding into South West London by working together. So we've got the 1.85 million around the National Trailblazer on children, young people, mental health. We also had £4.5 million which we put into extended access for general practice, which you now know we've got 8 to 8 hubs across the whole of South West London running. The Red Bag scheme, we got investment into that, and we've rolled that out across the whole of South West London. We've had 15.7 million secured to support our clinical record sharing across South West London, which has gone into our providers and other areas. We've got 600,000 from Health Education England to support our workforce priorities, and £500,000 about being a digital tools test bed for South West London. So by working together across South West London, we've actually brought in a huge amount of money as well into the transformation programme that we're doing. So I just thought it was worth highlighting.
Thank you very much indeed for that. I think it's been very interesting to know about some of the excellent events that you've put on, and I think there's a good example of people having a voice from all the community coming together to have a voice, to share their views, and I think it's also important looking at the integration, prevention and looking at healthy communities as well. I think that came out a lot. I went to one of the events at Kingston, which I thought was excellent. So perhaps I could just ask if anyone in the committee would like to ask any questions. Yes, please, Councillor.
Thank you. It says that the aim is to reduce by 20% the number of children and young people presenting at A&E as a result of self-harm over the next 3 years.
Yeah.
Which is good target. In Richmond, we did a report on risky behaviour, substance abuse and stresses which lead to self-harm. I'm wondering, have you sort of looked, there's a lot here which I have read, have you sort of done sort of a similar thing with looking at South West London as a whole?
You mean looking at risky behaviours across South West London?
Yes, and how that contributes to things like self-harm.
We haven't done a piece of work across South West London. What we have done is we've engaged with all the different mental health teams in each borough, so we've incorporated the learning that's been done at borough level into our system-wide thinking. But the approach we're taking is not just focused on dealing with self-harm. It is a whole programme around emotional and mental well-being in children and young people, and that will obviously include targeted interventions for those who are engaging in risky behaviours where it's linked in with mental ill health.
So what I do know is, and I know this from the JSNAs in Richmond particularly, but I think also in Kingston, is that alcohol and drugs with young people is a specific issue for those boroughs. And I know as part of the local health and care plans, so when we've showed the Merton and the Sutton ones, but as part of the local health and care plans for those boroughs, those have been specifically identified as areas around the start well that we'll want to work on together, because I do think, and it is about different boroughs having different needs, to be honest. And I know we have actually done a lot of work with our communications teams as well around alcohol and in those two boroughs. So we're looking at how can we work across agencies, so the local authorities, health services, to actually reduce the amount of alcohol we've got, because some of it is adults' problem as well in your boroughs, which I'm sure you're aware of.
And maybe if I just track back, so we started with self-harm, and we said if we really want to make a difference, let's look at the root cause. So we're doing a lot of work with primary schools. The hope is if we can get that bit right, they will be less likely to end up with alcohol and drug problems in their teenage years if we can support them early. So although it started with self-harm, we hope that the broad approach we're taking around early intervention will have benefits across a whole range of different ill healths in children and young people in their adolescence.
I have a follow-up question to that. With the National Trailways of funding, talks about the pilot boroughs and those that are catching up, the fast followers. I was wondering, is there a timeline? But when might fast followers be joining the pilots?
So I guess there's two issues with that. One is when and if will there be a wave 2 for the Trailblazers, so an opportunity to apply. I guess the second thing is we really would like to evaluate wave 1 so that we know that what we're rolling out is effective before we then replicate the model in other boroughs. So we're doing the initial survey in the spring term this year, and then we will do the follow-up survey at the start of spring term next year. So we hope then to do the evaluation through that spring term in 2020, and probably then by summer next year we'll be in a position to build a business case that would allow us to roll this out.
The other thing is that just to remember that we're not doing nothing in the other boroughs. So what we have done is we've still rolled out the initial South West London model, which was the initial support. So it's additional support we've got in the Trailblazer. If they do announce, because it's not up to us, it's a national. If they do announce another national wave, we will obviously bid for the other 3 boroughs and would hope to be successful, because we've already started, and it would be a really good thing for us to have across South West London. But that doesn't mean we're doing nothing, because we've still got the support going into the groups of schools in the other boroughs.
Yeah, I think the other thing to say is if we show this is effective and it really makes a difference to children and people, and it stops them turning up at A&E having harmed themselves, I think we'll be able to build a business case to do it regardless of whether we get national funding or not.
Yeah, I just wondered who would be best to approach to get the details of the boroughs. I mean, obviously we're very interested in what's happening with Wandsworth. You or Wandsworth?
I think our team, so we can direct you to the right person in our team who can give you that information.
If we take your details, we'll make sure that we can get you some information. Jay will do that.
Okay, which schools and has? Okay, that would be
brilliant.
brilliant.
We can tell you which schools it's in.
Right. Thank you.
Just a couple of things very quick. The first thing is the term STP, because I think if you go to elected members, when they hear STP, they still automatically think of this is cutting edge services, because that's how it all started. And I think just rebadging it something else would be helpful.
So we have rebadged it. I mean, I have to talk about STV because that's the national language at the moment.
Right.
It won't be in the future, but for us, what we will be, we are now calling it, and we will continue to call it, is the South West London Health and Care Partnership. So the South West London Health and Care Partnership will be how we badge this. I was asked to talk about STPs and where they've come from, where they've gone to, but this is a partnership. This is not about a plan. You know, integrated care systems will be the language of the future, and that's what it says in the long-term plan. But for us, it is our local health and care partnership. We won't be doing anything different to what we are already doing with our local councils, with our local providers, with our local people. So it will be an extension of that, and it is all about the partnership approach. So I think we've got the label right now with South West London Health and Care Partnership. I just think that sometimes people don't realise that's what we're talking about when we also say STP. So we've taken on board. I think we'll try and do that.
Okay. My second question, just as a follow-up. The South West London Partnership, I can see that it brings in inward investment from NHS and other bodies. Does it actually commission anything? Because at the moment, the commissioners seem to be, for me, Croydon CCG or NHS England.
So we're not a statutory body. The partnership is a partnership. It doesn't have any statutory. So any money that comes into South West London, you know, comes through one of the CCGs and is fed out into the system. So the only way you can't take money into something that isn't a legal entity. So we don't receive money or commission. But what we do is we work with all of the partners to work out how that money is best allocated within the system. So a lot of the money is allocated for specific things, like the children and young people mental health. So therefore it would come into us and then we would give it out into the system. You know, the stuff around the digital and the IT, I think most of that actually came through us but went to providers. So we bid as South West London, you know, we do it on behalf of everyone, but it goes through the statutory organisations. And you'll find that your statutory organisations will have a number of different routes of getting their funding.
I think I just want to make a very quick pause, because I really just want to say that I see a member of the public is here tonight. Now, normally I would insist on having questions being sent in, and I would say it's at 1 week before Wednesday, is that right?
It's very hard to do that when you haven't heard what's been said, of course.
But what I'd like to do is, you've been waiting, obviously I see you want to speak. What I am going to do is I'm going to allow the members of the committee to speak first, ask their questions first. I don't want to run too, I'm conscious of the time tonight, but if your question is related directly to the presentation itself that's just been presented, that's fine. But if you could just be patient for a while, I'll let one of the members ask their questions.
Okay, thank you.
Thank you very much indeed.
Thanks again. A little parochial, Queen Mary's, Roehampton. I've seen there's a slide about the future for Queen Mary's, and I know that's of great interest to local people. You mentioned over the next few months we will be analysing future health needs. Got a bit of a sense about spring, summer, when's it going to be happening?
What the local health and care plan? Which bit are you looking at?
I'm looking at, I've got it's page 56. It says Queen Mary's, the heading is Queen Mary Hospital, Roehampton. And then it talks about Queen Mary's becoming an urgent care centre.
Urgent treatment centre, yes. So Queen Mary's, just so you know, so I chair a programme board on Queen Mary's Roehampton, okay, and what we want to do is we want that to be a thriving unit for the local population. And we know that there are some services that have moved out there, so we have some space there, so we can use the space appropriately. So what we want to do is we're looking at all the possible options for putting services onto that site and how it should all work together. And one of the things that we definitely decided is that we're going to designate it as an urgent treatment centre. So that will be a slight extension of the services that are currently on there, because in order to be an urgent treatment centre you have to have certain diagnostics, you have to go over certain hours, you have to have certain medical cover. So all of that will happen. But we're also looking at, so we have got those diagnostics and we have got that medical cover, what other services could we have on the site. So we're not expecting to lose any of the services on the site, but what we are thinking about is how do we use the space to actually, so we're thinking about all the different options, and we've done some work I think with the public, and there's been some work done with the clinicians at both St George's and Kingston Hospital to look at what are the possible options that we could have. We don't yet have a decision on that. But what we are going to do is we're going to do some more work, and then we will come together and talk to local people about what the options might be for that. So that will be, I think we will probably have it around about June, July time. But it's an ongoing process. We're committed to Queen Mary's for the future. It's just about making sure that, you know, that we have the right services on that side. Okay. Any more questions from the committee? Okay. If you could just please state your name clearly so we can...
Okay, my name's Sandra Ash, and I wanted to ask a question about this idea of rebadging. You say in the paper I've got in my hand here on page 25 that you found that the perception of STP was that it was about closures of hospitals, hospital bed reductions, problems with the financial analysis, and whether or not local authorities were integral with the plan. And you're saying that you're putting that to one side, you're emphasising other things. However, may I suggest that STP still stands, the rules that you're working under still stand, and that's displayed by the fact that on page 60 you list your challenges under...
I don't want to interrupt your flow, but could you be able to ask your question?
Yeah, I will.
Thank you very much.
How can you say that things are actually changing as opposed to changing what you're talking about? Because on your page, the only page of your challenges in your programme is talking about Epsom and St Helier Hospital not having the workforce, the state of the trust buildings, and underlying financial deficit. That is what you see your challenges as.
I did emphasise at the beginning that it had to be directly related.
Well, it is. It's in the paperwork here.
Yes, but that is due to be presented later on in tonight's agenda. So what I'm suggesting is to keep to the flow of this.
Well, I am. You were talking about rebadging because it's not about closures. It clearly is.
I appreciate that, but I think what I'd like to do is I would like to give you an opportunity of asking your question when the other members of the committee have heard the presentation on the topic that you are wanting a response to.
Okay.
So if you don't mind being patient for a bit longer,
Fine.
you will have an opportunity in due course to ask that direct question about the hospitals.
Thank you.
Thank you. What I'd like to do, thank you very much for that. That's very informative. And I think I just wanted to add that you know how much we as a committee would be able to have this importance of the overview that you've given, and looking at some of the health priorities that you've mentioned, and that for us, again, that's about highlighting areas of major change. So the fact that it's a valuable exercise to have the update, and again, you know, perhaps we can invite you back at some point to give us an update on some of the outcomes that you've talked about in the presentation that will be taking place, particularly this summer. So if there are no more questions, if I can move on to the next item, and that I'd like to introduce delivering the congenital heart disease standard in London, and I believe that's Claire. I know that we didn't get to have your introduction when you both came in, so if you could just very, very briefly just introduce yourself.
Yes, I came from King's College at a patient of
Yes.
Thank you very much for seeing us at the
Thank you very much.
My name's Claire MacDonald. I'm from the team in NHS England London region supporting this programme.
And I'm Hazel Fisher, and I'm the programme director for this programme, covering cardiac and paediatrics. So, can I just check, because we have sent across a slimmed down presentation that we do have the same presentation, so it starts with the first page after the title being and I would just like to say thank you so much for inviting us today, and particularly I think we've been reminded listening to the very comprehensive presentation about South West London, just how important it is to be clear about the commissioning function. And Andrew talks about local being borough, sector being sector, South West London, and where we commission services, the specialised commissioning, we come in on regional, maybe plan, sector, and sometimes national commission services. So these are very specialised services. We understand today that you have a very full agenda, so we've deliberately taken this to quite a high level as an introduction, and we would be very happy to come back at another of your scheduled session to go into some of the further detail. And we have sent you a more detailed slide set previously, which members may well have, but just in order to sort of, with so much information to take on in this meeting, we thought it would be helpful to have a slightly higher level presentation. So, in particular, we are talking about the hospital called the Royal Brompton and Harefield NHS Foundation Trust. The Royal Brompton has 2 sites, and they are both in the North West London sector. One is on Chelsea, and the other is out at Harefield, which is on the edge of North West London. The specialised services which happen on the Chelsea site we've listed on the first page. So we are talking about services at a very specialist heart and lung orientated hospital, providing services to adults and paediatrics. And I won't read through the list unless, I mean, obviously we have the children's heart surgery, children's respiratory services, and that includes some very, very specific specialised services such as cystic fibrosis and primary cystinuria. And there are only 3 other providers of the children's cystic fibrosis services in London, and the Royal Brompton is the only provider of primary cystinuria services. As well as children's heart surgery, it has adult heart surgery and the related condition, so both with congenital heart disease and non-congenital heart disease, but also pulmonary hypertension and inherited cardiac conditions, and those services very closely linked in their delivery at the Royal Brompton. That's not the case in every hospital, but for the Royal Brompton it is. Adult respiratory services, and again you can see that the adult very specialised services replicate those for children. Thoracic conditions, which is primarily for the Brompton, lung cancer, they work very closely with the Marsden. Longer term ventilation in hospital and home, and their service is very much aimed at supporting people to go home who need long-term oxygen. And then adult respiratory ECMO, and they are one of only 5 centres in the country that provide adult respiratory ECMO. So it's a very specialised service. Why we've come to talk to you about this today is because we need to change services. Thank you very much. And that's particularly in relation to congenital heart disease services. So congenital heart disease is a heart condition or defect that develops before a baby is born. With the changes and advances in early diagnosis and surgery, the children are now growing up into adulthood. So nationally, children are being given to death, and there are nationally set standards for congenital heart disease. They were nationally consulted on and adopted back in 2015. And what we have been doing is working to see that they are implemented, because if you're going to set standards, it's important that you see those through to implementation. There are many standards, but and they situate across from something, a specialised hospital to a more general hospital, different levels. We're very interested in the delivery of standards at the special hospitals which we commission. 3 standards in particular have been causing a lot of national interest in terms of actually getting them right. One is paediatric co-location, so that the congenital heart disease surgery sits alongside other specialised children's surgery. The second is minimum volumes to maintain standards, so that's a competency standard, and then working on ensuring the right size of teams so that the team can cover over a 24/7 period with the right sort of rotors for the consultants on board. And Royal Brompton in particular can't meet the first of those standards. And we've had already one national consultation on how that might be resolved. And during that consultation, the Brompton came back and said, actually we think that there is a better way of doing this, and that would be to move their services. So this isn't just about changing services with congenital heart disease in terms of improving congenital heart disease services. It implies a move of all of the Broadway services at the Chelsea site. So, so clearly, trying to improve care, we need to look at the totality. Today, we have had two options put forward to us in terms of how the services could change. But obviously, as a commissioner, we're working through a commissioner process to assess these options and whether there are other justified options. But at the moment, we're focusing very much on these two. One is the Royal Brompton would like to work with King's Health Partners, so Guy's and St Thomas's, but also King's under the King's Health Partnership umbrella, to move the services across to Guy's and St Thomas's site. And that's important because Guy's and St Thomas's is already a compliant provider for congenital heart disease services. They provide ECMO services, and they would put forward the proposition that there are many synergies in the way that they would operate. The alternative proposition comes from Chelsea and Westminster and Imperial College Healthcare, and they are in North West London. And their proposition stems very much from the fact that they would like to move services within, particularly cardiac and respiratory services, within North West London to the Hammersmith site, and cystic fibrosis services to the Chelsea site, Chelsea and Westminster Hospital. That option supports congenital heart disease services moving to the St Thomas's site. So those are the services that we're looking at, the options at the moment that we're considering. What we're doing in that process is that we have set up, as you would imagine, a programme board to oversee the correct approach in terms of progressing a consultation, a case for change, and a pre-consultation business case. In that process, we have been engaging with stakeholders, and thank you very much for allowing us to come today, because this is part of our engagement. But we've been also working with voluntary groups, specific interest groups. We've contacted Health Watch. We've been working with local trusts and CCDs. And we've come today to talk to you because about 15% of service users at the Royal Brompton come from the South West London area. So primarily from Richmond and Wandsworth, but not uniquely. So that's our purpose in coming to you today. We are wanting to work with Overview and Scrutiny teams and VISIs in terms of forming a JOSC into the future, and obviously with CCGs into forming a decision-making bodies for the elements that are CCG commission, specialised commissioning decisions would be taken through our specialised commissioning board. Whilst we're undertaking that work, we will have a clear review by February, end of February, early March on our commissioning parameters, and we will be able to bring you back more detail actually on the specifics of where we are in terms of a more comprehensive case for change than the very high level that we've been receiving. So I recognise that that is a very high level, in fact, a whisk through, but in the context of all of your other work tonight, we wanted to really bring your awareness of the issue and that change in service so that you can consider, be aware of it, and then work with us into the future on more detailed change.
Thank you very much indeed for that. I think yes, I think my initial thought before I ask the questions from the committees that we probably would most definitely be interested in, you know, potential for future scrutiny. I think, you know, on the proposals and you know, how we can feed into that as a committee as well, I think would be very important. So I think I will ask if any of the members of the committee would like to ask any questions at this stage.
We were discussing it in the previous report, because we've got the slightly more detailed report as well. For us, it would be very useful to see both the national map where these services are at the moment, And sort of, we've just got a map where the geographical location is for us, and we've just got in terms of the presentation, that would be helpful. And I think we understand what we've tried to do in, co-located services. But again, just a bit more of an understanding of how that is actually going to impact people in the South West London area. And I recognise that at the moment it's high level, some of those details will come out as options progress.
Can I just add to that, not just South West London, but wherever else your patients come from, obviously I'm for Surrey campuses, it's marginal.
I pulled out the Surrey figures just when I saw you were here.
Thank you. One other question, if I may. On the two options, you're referring to the Royal Brompton Hospital and King's Health Partners proposal, refers to new buildings on the Guy's and St Thomas Westminster site. Are they existing new buildings to be constructed?
They are planning, obviously it's a long way to go yet, but they are envisaging a new heart and lung centre, so a centre of excellence, and that would be a physical new building.
So a new building, do you have any possible timescale?
It will take a while for it to consultation festival.
There is a requirement for consultation, so we need to go through consultation with the full case change, pre-consultation business case and preferred options, so that needs to be worked out appropriately. What the NHS England board have done is set a series of timescales which need to be hit in terms of the progress. And the next one for the trust, for that particular option, would be November 2019. And I think at that point, one could better replace the overall timescale. But the national timescale that we have been asked to work to is 2022 for the paediatric co-location element. But clearly, as what would be a major building project, we would be risk assessing that timescale and we already need to have to report on that timescale nationally. So that would be kept under review. But that's the aspiration from the national boards.
It would be possible between now and November for that option to move itself out to be on time?
No. The timescales should be deliverable for that option, but we need to go through the consultation and ensure that that is the option we would be going forward with, because we have got to do the full case to change process.
Yeah, just a clarification. It says the Westminster site of Guy's and Thomas, so it's not in the southeast region, it's over the river in Westminster?
So
it's not clear to me.
So by the Westminster campus, they mean the existing St Thomas's hospital site opposite the Houses of Parliament.
So it's not in Westminster?
It's not in Westminster.
Yeah, maybe yes, exactly. Maybe you shouldn't put that in there actually for clarification. I thought they might be expanding a bit more. Having worked the old Westminster.
It is London.
It's on the campus. It's on the campus.
It's on the St Thomas's.
Yeah.
Oh, thank you. Two questions. The first one is right at the beginning of the first presentation we had. It talks about should a credible solution not have been presented by the end of November 2019. I'd just like a bit of clarification. Does that mean if it doesn't come up, that's it? Then Brompton services will be handled differently and absorbed somewhere else? And related to that, I'm a bit confused. If Guy's and St Thomas's are already running this service anyway, why would we want a second service also running from their sites? Why wouldn't you just be commissioning larger capacity in on that site? It just seems that I can't get my head around that, and I'd like that explained.
So if the question is, why would we be commissioning more on the St Thomas's site, but with the Brompton moving there?
Yeah.
I think the effect of the Brompton moving is the congenital heart disease services to the St Thomas's side would mean that in London we would have two really resilient centres for congenital heart disease. One works between Gosh and Barts, and the other would be on the St Thomas's side. but that needs everybody, the organisation that is the Brompton and Guy's and St Thomas's, to feel that this is a deliverable solution. And by them coming together and offering this as a joint venture, it achieves one service that both organisations are happy to move towards. And we as the Commissioner will achieve our objective. In effect, it means that it would be commissioning a bigger service on that side. And this is the direction, this would enable that to happen.
Okay, so just to clarify, so you'd be commissioning a bigger service, but you'd be commissioning 2 services rather than 3.
So,
okay. And then the first point about what is the first statement on the slide we had on the bigger presentation about NHS England, progress should be reviewed over the next 2 years. Should a credible solution not have been presented by the end of November 2019?
So the national consultation that this was a result of, so this is a result of a national consultation that happened back in 2017. And in that consultation, the proposition was to simply decommission the paediatric congenital heart disease services from the Royal Brompton side and recommission it at the 2 compliant providers in London, which would be GSTT and Gosh Barts as the adult children's service. And what the Royal Brompton said was, hang on a minute, that would have really, we don't really think that you've thought through all the consequences to that, and we've got a better option that nobody has looked at. Actually, we could have a joint venture and move across with St Thomas's, and we would want to do that. Can you please look at that as a possible solution? And the board has said, yes, we're happy to look at it as a possible solution, but because that's quite a complicated project, we don't want this to carry on for ages. We don't want to say yes, we're putting some sort of sense of a backstop. Not a very helpful so yes, we'll consider it, but if it looks as if it's going to become so complicated, we want to reserve to ourselves our original consultation proposal,
which was
and that's essentially what they said, so that it can't just move, there's got to be a way of considering how to draw a line if it's not progressing effectively.
So, and can I just do one follow-up though, that the capacity of the service overall under that option would still be the same. So the same number of people could be treated, they'd just be
yes.
So there's no loss of service, but there is a change of location.
Yeah. Okay. Very important. The aim would be to improve services, not another.
Question. When it comes to inpatients and outpatients, we were talking about this in the pre-meeting as well. There's quite a high proportion of Midlands and East. Presumably that's because the service isn't provided in that region.
So there are services provided within Midlands and East, but the principle for congenital heart disease services has always been that patients can choose the centre that they go to. So patients can come to a London service. I think it's also important in terms of the geography of Midlands and East that some of the Midlands and East geography is very close to London. So the closer parts of Hertfordshire, the Lister Hospital, Bedfordshire, they have referral pathways into London for quite a number of services, not just for congenital heart disease.
Right, that's helpful, because actually this is the thing about the map and so forth. We couldn't quite work out the region, that's fine, okay.
We have a lot of patients nationally that come to Gosh as well. Gosh is a particularly popular hospital for people with children nationally. So, any more questions?
Thank you very much indeed for that presentation. And again, I just wanted to emphasise that yes, we'll definitely be interested in the future scrutiny of proposals, and we look forward to inviting you back again at some point. to give us an update, yes, please. Thank you very much indeed. Thank you. I think so as looking at the time, so let's move on to the next item, improving healthcare together programme update. Again, and then we have Sarah, and then followed by
So firstly, I want to say that we are meeting with Council Steers and the subcommittee next week, isn't it? So we weren't intending, because that's where we do most of the work on this programme, because that is the normal route for it. But I did want to mention that, and I will talk about it in my update, so I'm giving you a brief update overview at this meeting, but obviously we're going to do an in-depth discussion next week. One of the areas that I thought I would mention, because we're in the South West London space, is that we are doing work at the moment on provider impact assessment across South West London. If it should mean that there were impacts that we thought needed to be looked at wider than the three, I don't know quite exactly how you would want to do that, but I would suggest that because the prime group is the subcommittee, that you might want to invite individuals on in some of the boroughs that might be impacted if we felt that. But we might need to think that through, so I thought I'd mention
they have a right to attend anyway, so there's an open invitation on the Constitution anyway.
So we'll make sure we make people aware if that happens, of what they are, so that we can open that up.
If I get an early heads up, we can go and work with officers to actually formally invite if we find that there's information that needs to come to subcommittee a little bit wider in context.
Okay. So I am going to give you a brief overview of the process and where we are in the process. But obviously, just recognising that we don't want to bring sort of too much detailed information because we're doing it all with the other subcommittee, and that obviously we want to bring that detailed information to the subcommittee before it would come to the South West London committee anyway. So the challenges that we're addressing, and I'm sure you're all well versed in this, is that we have a number of challenges around Epsom St Helier Trust. One is that we have clinical standards agreed across South West London, and we know that all of our other hospitals, Kingston, Croydon and St George's, can meet those standards, but the workforce is an issue for Epsom St Helier, and they can't deliver those standards 24/7 as the other hospitals can. The estate is a significant issue for the Trust, and we know that, and there's pretty much pretty good evidence for that. And the Trust has an underlying financial deficit, which is getting worse each year, and I can definitely attest to that as well. So those are the three major challenges that we have with Epsom and St Helier Trust. And so the three CCGs have been working with the Trust, and actually CCGs have set up a separate process because it's commissioner-led, and we're assuring ourselves of what the Trust is saying to us, and also looking and making sure that we have oversight of all the work. And we have set up a clinical advisory group which is looking at the challenges and looking at proposals and looking at the future clinical model. We've set up a number of task and finish groups where we've looked at different parts of the model, so around specialties or around the district hospital services. And those clinical groups have been working throughout the last few months, in fact longer than that. And they have been testing the models, the proposals that the Trust has put forward, but also adding to those models with how we're working locally on things like the Sutton Health and Care Plan or the Epsom Health and Care Plan. The proposal is that actually most health services in the local area will not change. We recognise and we're not, we've been really clear that the major acute services, which are the 6 hot services that we identified that needed to be to reach clinical standards for South West London, may need to be co-located in order to make them work, but that a significant amount of what the Trust does, including outpatient diagnostics and that number of different services, will actually stay at local hospitals regardless of where you put major acute services. That's a real commitment for us, and we absolutely commit that both Epsom and St Helier hospitals will remain open on that basis. But we do recognise that something has to change in order to make sure we have high quality and safe services. There's a similar discussion to the one that we just had around specialist services at a different scale, but the idea being that actually if you can bring clinicians together and be of a certain size in order to deliver high quality services, you have better outcomes for patients. we've made I think the evidence is really clear around stroke in London. They're now going to, I think, roll out, I think that's one of the running areas in long-term plan that they'll want to do nationally across the country. It's been really difficult to consolidate stroke services. You know, people feel very strongly about their local services, but the evidence has been overwhelming in London about the outcomes for patients and actually the quality of care. And we're looking to do something similar in South London, but on a different scale and different solutions. So we have a number of potential solutions, as you know. We could co-locate, or we could locate the major acute services at Epsom, St Helier and Sutton. We've done a lot of work on whether or not there are other options. I can't remember, it's over 100 options we started off with, and we looked at whether or not it was physically possible to deliver it anywhere else. One of the things that we committed to absolutely is 3 CCGs, and I think this is important because I think in the past there has been discussion about actually removing major acute services from the area at all, is we've made the absolute commitment that we want to retain major acute services within our geography somewhere, and I think that's really important. And I think that's where in the past actually the clinicians are unhappy with the idea that there would be major acute services in the area. And we've made an absolute commitment as 3 CCGs that we want to retain those, and I think that's a really important commitment. So we've done some early engagement, and we have talked to a wide variety of people. Remembering we're not in formal consultation at this point, we're not ready yet to go to formal consultation, we still have more work to do. We are doing a lot of pre-consultation engagements to listen to people. We've done some discussion events. We've had some high street and mobile engagement events in all of the boroughs. We've had some focus groups looking at specific services that we are talking about. We've had some independently facilitated workshops. And we're also looking at community outreach to particular groups, particularly where we're flagging that we have specific groups that have inequality, so we're making sure we outreach to those. And we have looked at email, letters, telephone calls, and we've got a dedicated website and a Twitter feed. Obviously we can always do more, I'm sure we will try and do more, but this is not the formal consultation phase, this is still pre-consultation engagement. We have a stakeholder reference group, which is made up of a number of community groups, and they scrutinise our plans and how we engage, and they make recommendations to us on how to enhance what we're doing. So the feedback themes so far, and remembering that this is just engagement at the moment, it's over 1,000 people and organisations have taken part. The feedback is shaping the proposal, so we're feeding this all the time. This is an ongoing process. No decisions are yet made, I think that's really important, and no decisions will be formally made until post-consultation. Okay, so at any point, up until the point that the CCGs make a formal decision, we can make changes to the proposals. What we're trying to do is listen all of the time to our clinicians, to our local people, to what they're saying, and we're adjusting what we're doing accordingly based on that feedback. We're looking at a lot of work around travel, and we are looking at a lot of work around inequalities, and we're trying to make all of the reports that we are putting together available to the public, and we're putting those on the website as soon as we can. And you can go and have a look at that. So far, the kind of themes that are coming through is that there is a clear consensus that things need to change. I think that this has probably been discussed for many years in this area, and I think there is a recognition that something needs to change. But there's no agreement about the type of change that is needed. We've both people in favour of consolidating, so we do have people in favour of consolidating, and people wanting to keep things the same. It's very clear that people value their local services, and many responses have highlighted that people are willing to go further for better care. However, there's a natural sentiment to favour keeping services closer to home, and we hear that strongly. People raise concerns about travel and access to hospitals, and especially for those who are more isolated and less mobile, and we need to listen to those people. And the public have suggested that a status quo option for consideration as part of the options should be considered. So we are going to do that. So it actually does not deliver the standards, and it won't solve some of the problems that we have, but actually we think that having that in our options is important. So we will continue to include that and to assess that as we go forwards. So what are we doing now? Well, we have a lot more work to do still before we actually go to consultation or make a decision. We're doing an integrated impact assessment. Phase 1 was completed and it was published, and we're doing a further phase now. And there will be another phase done post-consultation, so that will happen in 3 phases. The deprivation analysis has been published, and we're doing a travel time analysis. Again, we've done phase 1, we're doing further, more detailed work on that. Since July, we've also been working with all of the local NHS providers, so that is all of the local acute providers in South West London and in Surrey. So we have set up a group with them where we are looking at, with the ambulance trusts in both Surrey and in London, at travel times, what the impact could be of all the different site options. And actually we did a first phase of that work, which we were given a view by all of the providers that none of the options at this point could be ruled out, that they did not have another option that they wanted to put on the table, but they wanted some further detailed work done on what it would be at specialty level. And so we've got high level numbers, but what would it mean for them at very specialty level, and lengths of stay and all sorts of things. So that work is being done now. I would hope that we were going to complete that by the end of February. If we haven't, it will take longer to do it, but you know, we are working with all of them. When we have got all of those pieces of information together, we will bring them together with feedback from our regulators, where we've given them some of the work that we have done, and if we are ready, we will go out to consult with the public formally. We will make a formal decision to do that at some point in the future, and we may or may not have a preferred option. We do not have a preferred option at this point. We do not have the level of information that we need to make that decision at this point. If we do believe that we have a preferred option or options, we will make that known, but we still intend to consult on every option. So even if the NHS commissioners have a preferred option, we will still open a consultation on all of the options I have said, which is the 3 options plus the stay the same. And then when we have finished all of that, we will take on board any additional information that has come through the consultation process, and also the further impact assessment before making a decision. So that's where we are at the moment. I can't give you a firm date on when we will go to consultation because we're still completing the work. One of the commitments that we made as an NHS was that we wouldn't go out to consult unless we were clear that there was a good chance that we would be able to get capital. At the moment, we have to go through a process with our regulators. They will supply us if they think we have, that they're happy that we go to consultation. That will mean that they are confident that we will have a chance of getting capital, and we don't know when they will be able to do that yet. So I've made the commitment locally, and nationally they have written that into some of their assurance processes. And therefore, even if we got to a point where we had the work that we needed, we wouldn't go to consult unless we were sure that there was a chance that we would get the capital. So we will wait for all of that to happen before we go out to consult. We could be ready as early as June, but we won't know until we've got the formal consent of the regulators. So it's still unclear exactly when we will go to consult at this point. So that's, I'm going to stop.
Thank you very much. If anyone's got any questions they'd like to ask. Oh, I do apologise, yes, Councillor.
Right, thank you very much. Please. Thank you for that. Yes, we've had a number of meetings of the subcommittee. We acknowledge that there has been consultation and engagement with the public, and that work has been done around the impact assessment, deprivation and travel times. Where we did have a concern was that we felt that the workshops were held too early, because all of the integrated impact assessment, the deprivation analysis and the travel time analysis all requires more work. So we came back and we said we would have preferred to have seen a much more robust work in these areas, so that that workshop has much more meaningful information. And in fact, we would be saying that maybe you should have another round of workshops to actually colour what you're going to say in the end, because it was very, very early in process, we felt. So that was our main concern. At the moment, we've been talking to the CCGs. From next week, we've got the Chief Executive of the St Helier Trust coming. We're very keen to look at the provider impact assessment across South West London. and if necessary we'll be calling the chief executives of those provider organisations in to have a discussion with them. In terms of, we are at the moment an advisory committee. When a formal consultation takes place, we become a mandatory committee, which obviously we will slightly change the reference in the way we would work. At the moment, the boroughs of Sutton and Merton have gone through their full council meetings and have retained the right to refer to the Secretary of State on their own independence. So it is possible that one of the councils could, and the subcommittee can as well, refer to the Secretary of State any changes that they feel we need. I'm more than happy, Councillor, I've got Councillor McCabe here who's been sitting on the committee with me. I'm more than happy to, if you'd like to come in on any topics that you might like to add to that.
Chairs.
Yes, please.
Yeah, I think the position of Merton is very clear. We have seen umpteen attempts to close a hospital. I took part in one of the workshops, and we were talking earlier on in the first presentation about people not trusting what has gone on, and that's because there have been umpteen attempts to close that hospital. Local people feel very passionately about keeping it open. People that I represent use that hospital, value it, really want to keep it, and they will fight to keep it open. And it's all very well saying we need to refresh. I think my colleague mentioned this not earlier on, the lady who tried to ask a question. Calling something by a different name because there hasn't been trust in the processes that have taken place earlier, and then creating the impression. And the impression amongst local people is that it is a done deal. There has been a decision made. People keep repeating, now we haven't made any decision. But the word on the streets is that they have. They're going for the same option that they've tried many times, and that really upsets the local people, and they will fight to keep them hospital open. And many of them are the least able to make journeys to some of the alternatives because they are elderly, they don't have access to their own transport, they are deprived. There's some suggestions that this whole issue of deprivation doesn't really make any difference. Well, come down and tell that to the people in Ravensbury Ward or St Helena Ward who use that hospital, and I think they'll tell you a very different story. So that's what I'd like to say. I hope it's clear, and I hope the position of the council is clear. It's not a party issue, as cross parties, or my colleague Andrew is not able to attend tonight, but we are united on that, and that is a very clear position of the local authority.
So, thank you very much, Steve. I mean, I just have one, I think perhaps two things. One is for perhaps Sarah to maybe just respond, if you can, on the point you made about closure, because I think having looked through the presentation and so on and read some of the outcomes from the engagement from last year, certain questions that were asked during that engagement process, July and I think September, October, were about ideas of a lot of issues coming out about transport, about which locations, for and against different locations, different options for the three locations, two locations I should say, but for the hospitals and different services. But is there a difference in terms of perception for the public about closure as opposed to changes to acute services? So I wondered if that was something that you had feedback on. Was it that they believe that it's about closure of an actual site rather than about changes to acute services? I wonder if that's something that
So there is no intention to close any hospitals, but we're not trying to hide the fact that we are saying there are some services that we think can only be done once, which is the major acute services. Most people that access services, particularly the elderly, would be still accessing the services in the same way through whichever site they currently attend, because 85% of what an acute hospital sees is actually that on a day-to-day basis. And in fact, we the model that we've got will enhance that kind of service and work with the community in a different way. But we do recognise that change is really difficult for the population and how much they love the local health services. I mean, our view is we want to make it better and higher quality for our local populations, but it's quite difficult to convince people that that's what we're trying to do, because often what they hear is closure and it causes anxiety, and we understand that. So I think we have got a job to do to convince people that it's the right thing to do, and that actually what they will get at the end of this is better services and services that are still close to where they live. And I obviously recognise that some people have a mistrust in the system. I can honestly tell you that we haven't made a decision, and it is us that is making the decision, because we sit on those governing bodies and we don't have the right information yet to make the decision. So I can sit here honestly now and say I don't know what the answer is, because I don't have the level of information needed to be able to make that decision. And I know people don't believe us. All we can do is prove that by carrying on doing what we're doing, and we will, when we do make a decision, we will do that in public and we will talk to people about it. But we certainly haven't done that yet. But we do recognise how difficult this is for the local population. I live in Sutton, okay? It's my local hospital, St Helier, and I want the best for my family and for the people around me. I'm absolutely convinced by the clinical arguments. I believe it's the right thing to do, but I do recognise that it's difficult for people to take on board, and I think that there is a mistrust, and we need to build that trust.
Chair, just put it. We have been saying all along on the subcommittee that you haven't anywhere near got that information. That's what I really need to emphasise.
Yeah, we haven't.
We have, you haven't. But when we talk to the CCGs, it sometimes comes across that yes, well, we just need that little bit of work, but really we know the answer. And I think that it might be the individual that's talking. Who knows? Okay. It's the way it's presented sometimes. But we are adamant, and this is why we said that we think the workshops were not placed in the right time, in a timeline, and it's very critical. Yeah. Those 3 analysis pieces of work are about individuals, they're about the residents. It's travel, it's deprivation, it's the whole impact, and the provider, the other providers. So we would be asking you to sort of have a look and see what your consultation is going to be, yeah, and with the boroughs, and then does it need to go out? As we said earlier, does it need to go out to other boroughs? Yeah. Because that impact, the provider impact assessment is much different than what the very thin line and information we've had recently.
Yeah. So we haven't finished that piece of work yet. And there are still scenarios and different sensitivities around that work that we're still working through. So and it's really down to quite a detailed level, probably more detailed than I've seen in most of these types of pieces of work around the provider impact assessment. So until we've got all of that finished and signed off by the providers, and we understand the impact, because what they're saying to us at the moment is they could still deliver all the options, that's what they've said to us, but there's differential impact on things like capital, what they would need to build, or workforce, or can they deliver, so they are still working through that, and we won't be able to understand that until that work is finished, and definitely that will impact on decisions, because we know that. On the workshops, they were a point in time. They are one input into what we are doing. We will make sure that we look at those in the context of any new information that we get. So, that was not what there was no clear sort of preferred option coming out of those workshops either. The only thing that came out of that workshop clearly was that staying the same, people didn't believe was the right solution. That was the only thing that came out of those workshops clearly. So there's still more work to do, and we will take that into consideration because it's one of the inputs, but it's not the thing we're going to make the decision on. We will make the decision based on all of the information that we have when we have it.
Thank you both. Yes, Councillor. If I can just very quickly say that I'd like to run the questions in a certain way. So what I'd like to do is, I know the member of the public has been waiting patiently to ask her question on the St Helier, I believe. So what I'd like to do is, if I could take your question next, and then I'd like for you to ask your question, because you've been waiting patiently.
Thank you.
And then go back to any other members who'd like to ask the question, because otherwise I am conscious of time. So if that's okay, right? Please, if you wouldn't mind. Thank you.
Thank you. Just to get an update and really some clarification around the other local NHS providers, because I understand that St George's might have listened to you and said, as you're doing this work, it's not sustainable for them to take on the closure of Congenital. And I think I'm concerned that on the impact of Croydon as well, the impact assessment seems to suggest the building of 4 new wards if Congenital was the option. You say that you need to get reassurance that capital will be available. Does that mean capital for, say, CUH? So before anything happens, make sure that capital is available. I still don't quite understand how you build 3 new wards on the CUH side.
So I don't think it does say 3 new wards. I don't think it does. And the numbers are moving, so I think they are changing. And so I don't want to commit to what the numbers are. I have responded to St George's. I'm happy to send you a copy of my response. Actually, we hadn't completed the work when I got that letter, and I was very clear about that. And actually, since then, I've had the response from all the providers that said all of the options are still possible. I did think they might rule out some because they thought it was impossible to deliver, but none of them had. And that's
so St George's have now updated their position?
Yes, well, from my perspective, they have. They've written to me since, from all the providers to the programme, saying their position currently is that none of the options are ruled out. They think that all of the impacts based on the initial impact assessment that we did, they can deliver, but they wanted more work done. And that's the piece we're doing. And on the capital, yes, it includes any impacts on the providers. So in order for us to understand the impacts, what they've asked for is like specialty level. So at the moment it's very high level numbers, but now they've asked for it at specialty level, which has changed the numbers of beds, because as soon as you start to look at specialties, some specialties are longer stay than others and so on. So it's actually changed the number of beds already by doing the level of detailed work that we're doing. And then what they can do is they can assess what capital they might need in order to deliver that, because it's all at specialty level. Then they can say, well, we could do that without changing anything, or we could do that. And they're doing that assessment now, and we're still working through with them. When they have done that, any of the capital impacts, those will go through an assurance process, because they have to say, does that sound realistic, is it right? And then all of those capital asks will go into the overall case. So it all comes together into the overall case, and it impacts. So if the capital for one option is much bigger than another option, that will impact on the financial ability to deliver it. So that's why I'm saying we don't have the information to make a decision yet, because it impacts on the financials, it impacts on the deliverability, all of those things. So we will take all of that into consideration as we move forward, and we're not yet at that point.
Right. If you could be very succinct.
Okay, I'll do my very best. A lot's been said and I'd like to comment on it. You say that the engagements, people mostly believe that things had to change. I went to many of the engagements and that's not what I saw and heard. I saw and heard lots of people have very strong opinions about retaining acute services at both hospitals. And might I say that I'm very much in favour of retaining them at both hospitals. I'm not in favour of keeping them at St Helier or at Epsom. I think we need all the acute services we've currently got at both hospitals. They're both at the centres of populations that very much need them, and they need to be near to emergency and acute services. I don't have a sentimental attachment to St Helier Hospital, but I do have a sentimental attachment to people's lives and well-being, and I think that taking one or both of those acute services away from our local hospitals would be detrimental and potentially catastrophic. I agree with the Royal College of Emergency Medicine, who said much the same about STPs. They said these plans are potentially catastrophic and lives will be lost if they're put into place. I believe you bear a very big responsibility if you could carry on with this plan to close our acute hospitals. We need them where we are, we need more of them, we need more beds, we need more staff, and we need more funding. And taking one or both of those services away will have potentially catastrophic results for all of us. and are asking you of the Scrutiny Committee to look very closely at what's being proposed and not just accept at face value what's being said. The Trust did a very detailed plan, and now suddenly that's disappeared, and we have the vaguest of possible plans from the CCGs with no detail, and yet you've engaged on those really vague plans.
Could I ask you if you have a specific question that you'd like to ask? Because I think
Okay, all right.
there is a distinction between
okay,
sort of a statement
a very
and
specific question.
Yeah,
It's been
please.
said for a long time that 85% of the services will remain at the hospital. That's been being said ever since this latest proposal has been put up. Since then, we've heard that outpatients are a thing of the past. I think, Sarah, you actually said at a CCG meeting. So if outpatients are a thing of the past and acute services are a thing of the past, what is this 85% of services that's still going to remain at both hospitals? Because it sounds to me like you're taking all the money-making things out of the hospitals, and in time they will be closed because they'd be declared as financially unsustainable.
Thank you. Can I say something just on the money to start with? Yeah. So on the money will work differently in the future, because what we want to do is not reward people just for seeing people over and over again, even if they don't maybe need to be seen that often. And actually outpatients is one of the things where we definitely can reduce the number that we have, and people can be supported differently in the community, and actually that's best practice. So we are looking at changing the way in which we deliver outpatients. But that doesn't mean that we would make other services financially unsustainable. What we're looking at now is we actually think that the way of working with tariffs doesn't work for us now. What we want to have is money that goes into the system and we deliver the right services for it. Not all outpatients will disappear, I'm sure, but there will be some that we will want to deliver differently, but they will still require specialist input, and they will still require GPs and other professionals to work with communities to deliver that. So that's on the first one. So we can make the money work differently is what I'm saying on that.
Will it still be 85% of services? That was my question.
We have to let the we have to let Sarah answer the question.
I think there are a number of issues there, Sarah. And on outpatients, I don't think we're saying we need to get rid of outpatients. We're saying we need to deliver specialist care differently. So you still need specialists. They still need to see patients. The question is how you arrange that. Patients will still need investigations to be done. Those will happen on the district hospital sites. You'll need specialists seeing them for their results. But hopefully, they can come in and have it done as a one-stop appointment with the investigations, the assessment and the management plan done at the same time, not in the current model. So that still needs to be done in a physical place. Those teams still need to be based in a physical place. I think also on the district hospital model, one of the things we're really working on is the enhanced support for the frail elderly. So we are talking about significantly better care for our frail elderly patients, both attending in an outpatient type setting where they come and see a holistic team, but also in a step-up, step-down model from the community. So when they start to get sick, quite quickly getting them into a district hospital bed, where there'll be a much better wraparound range of rehabilitation services to keep them well and stop them getting to the point where they need to be in a major acute hospital bed where, frankly, they don't do so well. And also getting them out of the major acute bed into the rehab setting in a district hospital site. We think we'll actually enhance the care for those patients. We know we can get them out of hospital quicker. The longer elderly patients spend in hospital, the more their function deteriorates, the weaker they get, and the worse they then fare when they go home. So we want to improve that journey significantly. I think the other point is this about actually making services worse for patients. One of the key drivers for this is the clinical standards. The point of the clinical standards is to actually improve the quality of care we deliver to patients. One of the things that Epsom St Helier say is, with their current configuration, they cannot do that. We don't think it's right that we have a hospital in South West London that is not meeting clinical standards that have been set across London, very much playing with national standards because it's the right way of dealing with patients. We can see that with stroke services, with cardiac services, where we have set clear standards, where we've reconfigured services to meet those standards, our stroke outcomes in South West London are some of the best in the country. And that's because we've been brave to change services so that when you have a stroke, you go into St George's, you get a really high standard of care, and you have much better outcomes. So that's what we want for patients. We want them in South West London to have the best outcomes we possibly can.
And it's a similar model to stroke, because the idea is, so with stroke, what happens now, if you have a stroke, the ambulance will take you to St George's, okay? If you have a stroke, they'll go past hospitals to get to St George's. because you will be given the right treatment very, very quickly. You'll stay in the hyperacute stroke unit there until you are ready to be repatriated back to your local hospital. And then when you're well enough, you go back to your local hospital and you spend the rest of your sort of rehabilitation in your local hospital, and then you go home. And it's a similar type model where the major acute services, which would be co-located, would see people when they are very, very acutely ill, and then as soon as they are ready, they would be repatriated to the local district hospital, where they would be, ending their visit with the hospital, and they would be rehabilitated very quickly back into the community. And the idea is that the district hospital would not just provide what hospital services currently provide, but they would provide that in and out support with the community and social care as well. So we would have teams that would be part of the district hospital services that would be going in and out of the hospital, and we would support people back into the community and into the district hospital rather than a major acute when they needed support. It's a new model and it's a different model, and actually a lot of people have said to us, particularly clinicians, actually this is the future of NHS services, this is the way we should be delivering care.
Well, they're already doing that at Epsom Hospital. So Prof Ward at Epsom Hospital, that's the model they're already running, and they're seeing very good outcomes through that. So although it's new to do it at scale, it's not completely new for us, even within Epsom St Helens.
Thank you very much indeed.
Where's the evidence for any of
I
that?
do apologise, Claire, but we have to have one question that we have answered as fully as we can for you. Are there any other questions from the committee at this stage? Because I'm sticking to my running order of questions. Are there any more questions? Thank you very much indeed for coming and presenting that to us. So we are going to, yes, we are indeed. Thank you very much indeed. I know. My point at the time was that I was prepared for Claire to ask.
My name's Sandra.
I do apologise, Sandra, to put her question forward because of the time that we have this evening. I would like to insist that I've allowed Sandra to put her question forward, but at this stage I would like to stick to what we've
It's a really quick question. I could have asked it in the time it's taken for you to explain that to me.
Well, I'm going to take a view that we have, I'm going to allow within 5 minutes, if I can, if you would like to, if it's a very quick question, and it's about the topic that we've just been discussing.
Yes, it is.
So what I'd like you to do then is I'd like you to introduce yourself and just to say if you're a local resident of the borough, and please put forward that I would like you to be extremely brief.
I'll be very brief. Thank you, Chair.
That's all right.
My name's Dave. I'm a member of the Keep House and Helier Hospital campaign. I am a local resident, and I'm also a taxpayer, so therefore a shareholder in the NHS, so I've got a stake in this. What I'd like to ask, we've heard repeatedly that this is all being driven by clinical standards and we have to improve the clinical standards. We have to meet these new clinical standards. So the question one is, how many hospitals in the country meet all of those clinical standards? If that's being used as a justification for why we must make a change, I'd like to know how many other hospitals in the country meet all of those standards. Number two, I'd like to know what evidence there is that consolidating all acute services, so A&E, maternity, intensive care, cancer care, coronary care, etc., from 2 sites onto one, yields better outcomes. I don't want an opinion on that. I'd like to see some clinical papers or some research that demonstrates that if this is done, the result will be a net improvement in everyone's health. Thank you.
Thank you very much indeed. And your name was Dave. Thank you very much, Dave. I think very briefly, if I may just direct.
So I was just going to say, if they look on the website, the clinical standards that the medical directors agreed across South West London are on there with all of the evidence referenced in it, and that's based on national London work and with the Royal Colleges. So obviously I can't give that to you now, that's on the website.
But not the Royal College of Emergency Medicine.
How many hospitals in the country meet the clinical standards? I don't know the answer for the whole country.
I do. The answer is 0.
Well, but the point is we're aspiring to meet standards because we know that delivers the best care for patients. So we might not be delivering at the moment, but we have to aim to deliver it because we don't think it's acceptable to provide substandard care.
I think 7-day services is an aspiration for all hospitals across the country, because we know, and there's evidence that if you have full services 7 days, 25 days, they deliver better outcomes for patients and less deaths, and that's really important.
But you intend to reduce the number of consultants by half.
I will have to insist that we end the question. I have allowed the two questions to be heard today, and given opportunity to the panel to answer your questions. So, I would say that this isn't this will, we will be bringing as a scrutiny committee to. This topic will be coming back at some point to scrutiny, I would presume, and therefore there will be an opportunity for you to submit your questions. So we look forward to that happening. Should you want to come back again,
we'd love to. Is there any opportunity for us to actually come and talk to you?
I'm always open to talk to anybody. So my answer is, for me personally, I'm very happy to talk to anybody, but I am no expert in this field. However, I cannot say at this moment in time how that would work. I would need to seek advice on that. But certainly, this is a lot of this information will be in the public domain, and I'm sure there'll be lots of options, as you have engaged already in that process. And I think feedback is very, very important. And as I understand at the moment, there is consultation, there's a lot of stages that we need to go through. And it's your feedback that's going to be vital during that process.
Like the opportunity to talk to the scrutiny committee, that would be really good.
Of course. Of course, yes. And also there's the subcommittee that you can attend as well, as Councillor Steers pointed out earlier. And I would suggest that, it's probably going to be a very informative exercise. I think, there is the option for you to attend that.
But talking is good.
It is indeed, but thank you very much, and thank you for your patience this evening.
No problem.
So I'd like to move on. Thank you very much indeed for presenting as well again. I'd like to move on to item 7 on the agenda, which is the trigger document. And I believe, David, you want to... Hello.
Thank you, Chair.
Thank you.
Hello, councillors. Just briefly to give a short verbal introduction to the brief paper which is setting out the trigger document. The trigger document is the result of a number of conversations that have taken place between Chair and scrutiny officers and our NHS colleagues, Sarah Blow and others, in order to try to reach a point where we can have an arrangement whereby when there are proposed changes to the delivery of health services in one or more of our local areas, that we have an opportunity to be advised early on in NHS colleagues and commissioners thinking about those proposals, and that they share with us some of their early thinking in order that the relevant scrutiny committees can understand what the proposals might be, what the impacts might be, and can then make a determination as to whether or not there will be a need for any scrutiny engagement or formal scrutiny activity. So I would commend to the committee the use of the trigger document, which you will see as Appendix A to this report, which Sarah and colleagues, I understand, are taking around the relevant governing board meetings in order that they can be apprised of this process and that they can then be in a position to make use of the process in the future.
Thank you very much. Would you want to...
I was going to say, I've used trigger templates in the past in previous organisations. I know that this has gone around a number of loops, hasn't it, in the past, and we couldn't get it agreed, and then I said, well, actually, you should be able to do that South West London, because I've used them elsewhere, and I think this is a more agreed version of what we could do, and I think my team are very happy with it, so we'll take it round to the governing bodies. I'm sure they'll be supportive of it. It actually helps us, and it'll help you when we make decisions about how to take work forwards.
Thank you, Sarah. Are there any questions on the trigger document itself?
Chair, I'd just like to support the concept. We've had situations where there have been significant changes, and it would appear that sort of, people consult as an afterthought rather than a part of the whole planning for such a process. acts like it irritates the local community, and I think this is to be commended.
Thank you very much indeed. I think that's something that, again, we said at the time when we were looking at this, that this is about, early indications. So please, yes, Councillor.
First of all, thank you very much. I know it's been a work of perseverance to get this document done. So thank you very much for all the work you've done. What I struggled to understand sitting on the health committee is when NHS England commissioned services and when CCG's commissioned, because we've had a recent issue with community dentist services, which has been commissioned by NHS England to St George's and Hawkins, and now they're in financial trouble, and this seems to be the case. How does would this trigger document work at all? And can we have a list of what does NHS England commission and what does CCG's commission? Because that would be really useful.
So we can definitely do that, but it won't be a list of every, we'll have to do it in the round because specialist services are quite large, so we'll just have to say specialist tertiary services. The problem is this is quite long, so we can give you a list. I mean, I'm hoping in the future it will be, we will, my view would be go to your local system because they will be able to tell you anyway if you have any concerns about any services, we can do that. I doubt very much I'm going to get the trigger template signed off by NHS England because it's a national body, so specialist services, there's only one national body for specialist services. They do have local teams, but it's something that they just have to be signed off by NHS England nationally, and I don't think I'm going to get that, to be honest. But what we can do is we can commit to doing this locally, and we can also speak to our colleagues, which I have done today with specialised commissioning, and said to them, can you talk to us and tell us what you're doing, because then we can keep local people informed. So we will try and make sure that we get that right within the NHS. It's not all that easy. We recognise there's lots of organisations even within the NHS. But we'll definitely get you a list, and I would suggest you do go through your local organisations, because even if it's not them, they'll be able to tell you who it is and they'll be able to find out. But I don't think we'll get a trigger template for them. What we can do is, if they tell us about it, we can ask them to fill it in, yes. But unfortunately, it's slightly separate.
Any other questions? Yeah. Conclude the meeting. So if there are no other questions, may I just thank you all for coming in to present. And of course, thank you for hosting. And therefore close this meeting at 8 minutes past 9. Thank you very much indeed.